All right, Dr. Greenwood, you just participated in a panel called The Future of Women's Breast Health. And you work with an organization, a top-notch research organization, UCSF, and you're doing some cutting-edge research that will inform the future of women's breast health. Talk a little bit about what you're looking into.
Sure. We have a few major prospective large multi-institution studies we're involved in now that I think really are focusing on how do we personalized medicine. I think we've learned not all breast cancers are the same by any means. There is a huge range of cancers that are very aggressive and also cancers on the opposite end of the spectrum that may never affect a woman's health. So a lot of things we're researching are different ways to personalize medicine. For example, one of our large trials is called the I-SPY 2 trial, and that's for patients with larger newly diagnosed breast cancers. And those patients are randomized to different clinical arms of certain chemotherapeutic drugs and new drug regimens, and we follow them with breast MRI, so something the radiologists are very involved in, and we do very serial breast MRIs to evaluate their tumor's response to the arm of chemotherapy they're on. So those women who are doing well stay on that arm, and we keep following them with MRI with a goal of a complete pathologic response at surgery, meaning the tumor's gone. Now, if a woman's on chemotherapy and we see her MR and she hasn't had any response, meaning her tumor's not getting smaller, her lymph nodes don't look any smaller, MR is a great tool to show us preoperatively that that patient isn't responding to those drugs. So based on the MR results, she might go on to a different arm of chemotherapy. And that's one of the large studies we're doing now, which I think is really exciting because it really changes management with very short-term follow-up. Another large study we're participating in is the Wisdom study. There's a lot of controversy right now over when we should start screening, if we should screen, how often, and I think as a radiologist, we have a lot of data showing that we strongly advocate for annual mammography starting at 40 in average risk women. But this study is looking at personalized medicine and basically putting patients based on a risk assessment into different screening arms as far as if they start at 40, start earlier, start at 50, how frequently we screen them, and with what imaging modalities. So really exciting, couple studies going on at UCSF, centered at UCSF, but multi-institutional across the country.
What are some of the practical implications for women?
Sure, so I think especially with the Wisdom trial, I think it's a great trial that really empowers women to make a choice. So they can pick if they want to be in the research arm where they would be randomized to either standard screening versus personalized based on a risk assessment, or they can just choose to be observational and continue doing the screening that they're already doing. I think it's a great, it provides women with a lot of knowledge. All the women in the study will undergo a formal risk assessment with genetic profiling and really understand what their risk is for breast cancer, which informs not only them, but potentially their future children, sisters, mothers, etc., which I think really is a lot of knowledge and gives women a lot of power to decide, what their screening should be.
We're at RSNA, and when you look around, you'll see the latest and greatest in technology. But when we talk about the future of women's breast health, that's just one of the components. There are some other components that may be more pedestrian that we really ought to think about as a healthcare system. What are some of those things?
Yeah, so I think right now at RSNA, we're always so focused on technology. AI is everywhere. MRI, tomosynthesis, we talk about all of that. But I think in the future, I think we're going to have other types of tools to really personalize medicine. I think that breast health is a team effort, and I think that implementing the right team for a patient is very important. I think that's something we're working towards, where at UCSF, we have a hereditary cancer center. So patients who have, first say, a cancer and they have a BRCA mutation are more treated as that group of patients. So you might have pancreatic cancer, but it's related to BRCA mutation, so we can target whatever the mutation is, as opposed to lumping all patients with breast cancer, pancreatic cancer together when we know they're really different, totally different diseases, even if it's the same organ. So I think things like having these centers with really personalized medicine, targeting the specific type of cancer or mutation a patient has is a really exciting thing that's not as technology-based as a lot of the other things we've talked about.
And for women, what recommendation or advice would you give them in terms of what they can do on a daily basis to contribute to their own breast health?
Yeah, I think that's a great question. I think that as women, we really need to listen to our bodies. I think very frequently if you feel like something's changed or something's different, we tend to blow things off, and I think it's very important just to be in tune, and if you feel a new lump or bump or have a new symptom, to bring it to your doctor's attention. I think to just educate each other about our past experiences, and to really just, read about things, participate in research studies that are available at multiple hospitals across the country, and just really engage in your own healthcare. And I think that's something really exciting about the Mammosphere that LifeImage has, is that women really can take power by getting access to all their prior images, and that really helps their doctors find breast cancers earlier. So those are kind of some things I think that are great for women to do.
Have you noticed a difference in terms of female patients and your patients being more empowered and being more active, engaged in their healthcare?
Yes, absolutely. I find that my patients every day ask me about screening, and they want to know the data, and they want to know why there's all this confusion. And I find that they're very, very willing to go the extra step to do something, like go get their priors from another facility, even if that means driving, 45 minutes. So I think they're really trying to take care of their health and really take control, much more so than in the past. The patients are much more educated, so any way we can make the process easier for them, I think is great.
Talk a little bit about the patient experience. That's changing in healthcare. The consumer is very accustomed to certain conveniences that's brought on from the consumer tech world that they don't have in healthcare. Do you see that slowly changing, or you still think there's a big gap?
I think that there's a gap. We talked at the panel a lot about how easy something like Amazon is. You just click and you have something, and yet for our healthcare, something much more important than whatever I might be shopping for on Amazon, we can't do that yet. So I think that the Mammosphere Project really addresses that gap, so that patients can have just access to their medical records much easier. And for whatever reason, imaging seems to be what's lagging more than any other part of your medical record.
Well, let's skip 10 years down the line, right? Let's talk about the future of women's breast health. You hear a lot about AI, you hear a lot about personalized medicine. How far along are we? Do you see some major shifts, or you still think that there's some progress to be made?
Yeah, 10 years from now, what I would hope is that, I think we've talked a lot about AI, and I think its role in mammography would probably be looking at all those normal mammograms. The vast majority of mammograms are negative, are normal, and I think AI, hopefully in 10 years, will be able to recognize what mammograms are normal and which ones need a radiologist's eyes for further evaluation. I think within 10 years, especially what we're seeing here, that's a reasonable time frame to see that happening. I think we're going to be doing much more abbreviated MR screening. I think we're going to hopefully have identified patients who are at higher risk at younger ages to figure out when they need to start screening and start screening them earlier. That's really the group of patients, the young patients, that I hope we have made significant progress for, and I think that starts with identifying who's at risk and then applying the technology we have to figure out when to screen and if they have anything abnormal as early as possible.
All right, thank you for your time.
Thank you.